I think it's really wonderful that we have a moment to really reflect on mothers around the world on International Women's Day. And when I told my father, who's living in Boston, that I was giving this talk, he reminded me of the fact that my own grandmother's birthday was right around International Mother's Day, and we actually celebrated International Mother's Day as her birthday every year. My grandparents were actually very politically active. The man in that picture, Jack Stachel, was one of the leaders of the Communist Party, and my dad further reminded me that International Women's Day was first started in 1911, and it actually was International Working Women's Day, and it was started by the American Socialists group. So I thought it was very fitting that I got to speak today. I wanted to also speak about another very important mother in my life, which is my mother. What I wanted to tell you was that when she had her first pregnancy in this country, my parents were extremely poor. They did not have good access to health care, and she got very poor health care during her own labor with my older brother. And she went home, and apparently a little bit of the placenta, which is the afterbirth, was left inside, and she got extremely sick, so sick that when she was brought back to the emergency room, they really thought she was going to die. And 2 of the 3 doctors working on her gave up. And one doctor said, I want to give it one more try, and did something at that time to resuscitate her, and through antibiotics and the emergency medical care that she got, she did survive clearly, and went on to have me about 5 years later. But we're going to be talking about mothers that may not get that second chance. And around the world, hundreds of thousands of women die from pregnancy-related complications every single year. It's very hard to accurately document, but we think it's probably at least 350,000, and some estimates are 500,000 women dying every year from pregnancy-related causes. And this is something that we consider and take for granted nowadays. It's a healthy event. If someone gets pregnant and they go to the hospital, you know, we expect that there's going to be a joyous outcome, but that's so not true for many people around the world. And if you look at the world map, what you see is that the areas in which mortality is the highest, are you all able to see? I'm feeling like I'm blocking you. But where mortality is the highest are also the areas where poverty is the highest in the world. And you see that on this particular map, Asia and Africa are just clearly overrepresented. The areas where mortality is the highest are the areas in red. And in fact, if we were going to redraw the world map to show the territories with the largest contribution to maternal death, this is what the world would look like. The absolute numbers are highest in India, which you see as a very large area on the map, but the second highest is Nigeria, which is this flesh-colored part of the map. And as a student at UC Berkeley in the School of Public Health, pursuing my doctorate, I was actually invited to go to Nigeria. There is a partnership right now between the Bixby Center for Population Health and Sustainability and a university in Nigeria called Ahmadu Bello University. And the idea is to try and increase the capacity of Nigerian doctors to study maternal mortality and to look for ways to reduce maternal mortality. Why Nigeria? Nigeria is the largest or most populous nation in Africa. And in the world, it actually accounts for 2% of the world's population. But from this slide, you'll see that it also accounts for 11% of maternal deaths. There are different ways that we use statistics to describe maternal mortality rates. One is called the maternal mortality ratio. It's the number of women who die for every 100,000 live births. In our country right now, it's about 17 per 100,000 live births. In Nigeria as a whole, it's 1,100. And in the areas in which I work, it's more like 3,000. So what does it mean to be living in a place where so many women are dying? It means that everybody knows someone who's died in childbirth. And it means that for women like these who are awaiting prenatal care at a clinic, they are actually facing in their lifetime a 1 in 13 chance of dying during childbirth. And they're not dying from rare diseases. When I went there, I thought, well, maybe there's very unusual diseases that are really complicating. But it turns out they're dying of the same things that we have here in America. I was an obstetrician for 14 years before I went there, and I've treated all of these conditions: bleeding, infection, Obstructed labor, which means the baby's too big to fit through the birth canal. We do C-sections all the time. In fact, we're criticized for doing too many. And eclampsia, which is a blood pressure-related problem. But in areas where it's very hard to access quality health care, these become life-threatening events. And in my first 2 weeks in Nigeria, I saw more complications than I had seen in my entire 14 years as an obstetrician in this country. So what I wanted to do now is take you through what it looks like in one of the villages outside of the city where I do the research, and then bring you inside the hospital to show you what conditions are like, and then show you where I've decided to put my energy to try and help in a little way to try and reduce these outrageous numbers that I've already described. So this is a city called Shikadam. It's a village that's outside of a fairly large area called Zaria in northern Nigeria. It's a Muslim community. And if you were to walk in the village streets, what you would see is men, and you'd see children of both sexes. But what's noticeably absent is women. Women are actually kept in seclusion behind those mud walls that you see in the picture. Boys are encouraged to have education. They might get both secular education, and here you see them studying the Quran. But for girls, it's much less likely that they're going to have that opportunity. These girls are doing something called hawking, and what they're doing is selling things that their mothers have made at home, but the mothers aren't allowed to go out in public and do this, and so they send their daughters out so they can earn a small amount of discretionary income for home. By the time girls are this age, they're not that far off from getting married. The average age of marriage in this village was 14 and a half, and it's very likely that there'll be a pregnancy pretty soon thereafter. This is what it looks like when you go inside those mud walls. In this particular region, as I mentioned, it's Islamic. It's not uncommon to have multiple wives if you're a man, so polygamy is practiced, and so there may be 3 or even 4 wives. And it can actually be quite a big community in there. I saw sometimes some housing compounds where there were dozens of people when you have an extended family, because women are actually encouraged to have quite a large family. It's not uncommon for people to aim to have 7 to 10 children. Women engage in domestic activities there, things like taking care of children and washing and cooking. But there's another reason why I'm showing this picture. This is the same conditions in which women are giving birth, because 97% of women in this community give birth at home, in an area where there's no running water, no electricity, where they've never been educated in a school, they've not learned about reproductive health, and where the poverty is so high that the average income here is less than $1 a day. So when you add those factors together, you start to understand why it could be that a complication in pregnancy could lead to such a disastrous outcome. There's been a model that's been described as the 3 delays to try and explain the factors in a more orderly way. So those 3 delays start with delays that happen at home. So what happens at home is that if a woman is giving childbirth, and when I spoke to women there, they said they actually give birth, they actually labor on their own. They're not with a group of women who may have had experience. So they're by themselves. And it's very hard to recognize when something's gone wrong. For any of you who have had a baby, you know that there's really nothing that prepares you for what labor feels like. It already feels wrong. So how do you know when something's really wrong? And then how do you make the decision to do something about it when you're so poor and there's no transportation and the nearest hospital is quite far away? So recognizing there's a problem and making that decision, and then convincing your husband, who's the only person who can make that decision, is something that can take a very long time if it happens at all. Next, there's a delay in actually getting to a health facility, because it's very hard to find cars, it's costly. In the village that you just saw, there were 1,000 families, 3 vehicles, and only 1 of them worked. So it can be very, very difficult to actually reach a hospital. But where my work is focused is on what happens once you actually get to the hospital. Because there are a lot of problems that exist within the facility itself in terms of supplies and staffing, and now what I'm going to do is actually bring you inside and have you see what I saw when I first went in 2008. So this is a very large hospital. It is a state hospital that serves a city of 1.5 million people. It has 160 beds. This is just the surgical ward. So the conditions I'm showing you are not in the most rural outpost. It's actually one that's connected to an electricity grid. You see the wires there. Yet in Nigeria, electricity is rationed, and you will see no more than 12 hours of electricity per day, even under the best of circumstances. And when I was there last, in the middle of 2010, the hospital was only getting 2 hours of electricity a day. Family members are extremely important to care. They really take on a lot of what we consider nursing functions in this country. And during the day, family members stay outside preparing food, and then they'll bring it in to feed their loved ones. They do the washing, and they try and take care of them. They give them medications. But then at night, they actually come in and sleep on the floor or on the bed or next to patients. This is labor and delivery. If we had more time, I would ask you how many differences you see between this particular room and one that you might consider more average in the United States. But there's none of the monitors, clearly, and the lights and all the technology that we associate with childbirth in this country. If you turn from that part of the room we were just looking at to the other wall, you'd see that this is the only area for both water and for sanitation. And the fact that there wasn't adequate electricity meant that instead of autoclaving and sterilizing equipment the way we do here, they would dunk equipment in those buckets you see on the right side, the blue basins, in different solutions of bleach and water. And there was no running water. If you see the sink on the left, if you look closely, there's actually no attachment to the tube from the faucet. So the water we used to wash our hands or to wash things when we were taking care of patients were in those two large buckets there. And that was the same in the operating room as well. The problems with electricity affected the surgical care. You're seeing here an operation taking place where the fact that they have the overhead light is not correlated with the fact there's no light on the table because they couldn't use the light. Most of the time I saw there, they weren't using a light over the table, and they really relied on the sunlight that was flowing in from the windows as the only way to have light for care. What that means is during night it's very difficult to do surgeries. And they do have a generator there, but fuel's expensive. And I was there during a case when the lights went out during a C-section. And it was only the fact that the person who was visiting with me and I had flashlights that we were able to finish the case. There's also not power to refrigerate blood, so it means that if a transfusion is necessary because someone at home has been hemorrhaging, once they get to the hospital, they have to find a family member who can donate blood, has the same type of blood, has no infections, and only then can a transfusion occur. And there's no communication system other than just looking physically for a doctor on the grounds. And so, for example, a woman like this who was bleeding and required a C-section, even though she was in the hospital and a nurse was there, the messenger, after 4 hours, couldn't find the doctor. It was only when I went and actually knocked on the houses of all the doctors that were in the compound around the hospital that we found someone that could come to do surgery. But by the time we came back, it was too late and she had lost her baby. And I saw that over and over again. I've been to Nigeria now 7 times trying to document this type of thing. And when it's late and the power is out, this is the only light for labor and delivery. This is a kerosene lantern, and what you're looking at is the maternity ward. If I turn the lights on, you would see a dozen patients behind the nurse's desk there. That is the nurse's desk. So I know this is pretty intense to look at, and this I just gave you is kind of like a rush through what it was like during that first time I went to observe. And I came back pretty devastated because I knew that there was going to be issues in the hospital. But I really thought that my skills as an obstetrician would come in handy and I could perhaps teach technically ways that people could improve care. But once I saw the conditions in the hospital, I said, I have no business giving advice about clinical care until we take care of some of the most basic infrastructure that's going on here. And if you were to look at all the different issues in the hospital, there were a lot of places that I might have begun to try and address the problem. But I happen to be married to someone who teaches about solar electricity. And he says, if your only tool is a hammer, then everything looks like a nail. And so I was writing back to him from Nigeria, telling him stories of how the lights would go out and this would happen. And he said, Laura, come back home. I think we can set up a solar energy system for the hospital so we could really help out. And so the area that we decided to approach was this area of electricity, light, and communication. And I came back exactly 3 years ago, almost to the day, and we founded this group called We Care Solar. And We Care actually is an acronym. It stands for Women's Emergency Communication and Reliable Electricity. And the idea was that we would design a solar electric system to help to power a blood bank refrigerator and lights for the maternity ward and lights for the operating room and some of the equipment that couldn't be used, like a suction machine. And so we took a team of students, and the people there are actually, the two bookends are both graduate students at Berkeley, Melissa Ho and Christian Casillas, and the man next to me is my husband, Hal Aronson. And we put together a team, and then we designed a standalone system, an off-grid system using solar electricity, using the principles of a solar panel collecting light during the day, translating that light into electricity that's stored into a battery, and then at night or in rainy weather, using that battery to try and power things like lights and suction machines, as I just mentioned. But before going to install this system, and here's my husband working on one of the very first systems, I said, you know, Hal, can you come with me and really explain what we're planning on doing? He said, no, I saw the pictures of the hospital. I'm not going there. You're going to come and learn electricity from me. And so I took one of his solar energy courses. And I said, well, I really want to show a model of what I'm thinking might be helpful there. And he said, well, why don't you set up something small that you can bring there as a demonstration kit? And we decided to make something that was so small it would fit in my suitcase so I could get through customs without explaining what I was doing. And so he set up this system. I said, look, I know I just took your class, but I'm going to forget. Put everything you can, nail it to a board so I don't have to do a whole lot of wiring. And so he rigged up this system that I then took with me back in the summer of 2008 to show the doctors. And I said, look, we're thinking of using things like LED high-efficiency lights, and we're thinking, what if you had walkie-talkies, because I know cell phones cost a lot of money to use there, and we'll power everything off of the sun. What do you think? They said, we love the idea. Can you leave the suitcase? I said, no, this isn't really a suitcase for you. It's just a demonstration. This is my husband's equipment. He said, but it's going to make a difference right now. So we decided to leave the suitcase there while we did further preparations to do a fairly big installation, which I'll show you in a minute. And it turns out that even a very small amount of electricity made a very big difference. So here you're seeing some nurses trying to work with both a kerosene lantern or what it's like using a headlamp that has an LED light. And in the eclampsia ward, where the only light one night was a candle, the nurse couldn't see what she was doing to put in an IV line. Just giving a little LED headlamp allowed her to see what she was doing. And even in the operating room at 5 o'clock at night, you can see how much easier it is to see when you have a bit of LED light. And then I brought with them during that trip the walkie-talkies, and now instead of hours to assemble a surgical team, people could be notified within minutes. And so you would really avoid a lot of these delays. So while they were using this, I then hired a Nigerian contractor, and I went back, and we were able to actually secure some money from the Blum Center for Developing Economies to fund this project. And so then we went back and did a regular solar installation, and the maternity ward went from looking like this at night to this, and the operating room went from looking like this to this. And this is with 15 watts of power. Does anybody know what an average incandescent light takes for power? Like in your lamp or in your house when you go and buy a light bulb? 60 watts. So that would be for like a lamp in your house. With LED lights, this is 15 watts. And look at the difference that can make. And so it occurred to us we could do a lot with a very little power. And then we brought in a blood bank refrigerator. And in this particular hospital, inside the hospital, the death rate dropped. They have now, when I call them, they say there are some months no one dies at all every month, where it used to be 4, 5, 6 people dying every month. And the amount of patients they could see went up. Because one thing I failed to mention to you is one of the things they were doing was turning people away when people would arrive with complications needing care because they felt they couldn't bring them in to take care of them. So more people were taken care of, yet the death rate was going down. And honestly, I thought my job was done, and I would go back to being a graduate student and writing my dissertation. But people at the hospital had another idea. They started bringing me to clinics to introduce me to their friends. And their friends would say, hey, our clinic does deliveries, and we don't have light either. How come just the big hospital gets the light? And I said, but you don't understand. This is just my husband and I and a couple of students. We're really not a big organization. But then we said, what if we take that idea of the little suitcase-sized system and we package things on purpose inside a suitcase and deliver a limited amount of energy, but with these very high efficiency lights. Maybe we could actually make a difference without thousands and thousands of dollars, but with a limited low-cost system. What could we do? And so we started creating these solar suitcases to power lights that could be used for childbirth or for surgeries and cell phones or walkie-talkies, and to recharge chargeable batteries for those headlamps that I showed you. And so we started bringing them to different clinics. And I don't know if you've ever heard of the Millennial Village Project, Jeffrey Sachs's work, but this is, 2 of the clinics now have our solar suitcases, and the midwives were very excited to use these. And people would tell me stories when I'd go back. I would talk to someone, I'd walk out crying, just realizing how a little light could make a difference. In this particular clinic, I remember one of these midwives telling me that she had been trying to do suturing, sewing someone who was bleeding, holding a candle in one hand before we had done this. And then here is an operating room with only one light bulb, 5 watts of power, but that's enough, again, to make a very big difference. And so I could have told you that the story would end here, but it turned out someone in the New York Times wrote an article and mentioned us, and I started getting emails from around the world, because it turns out this is really a problem all over the world. And if I would show you that same map of maternal mortality and superimpose where the areas where electrification is the worst, it's almost an identical map. And so we now get requests literally every week or every day from people wanting to have a little bit of power. And so now I'll show you some of the places this little suitcase has traveled. And many of these I've not yet gone to. So Rwanda went with somebody. In Mexico, there's an area that's completely cut off from power where the maternal mortality rate is identical to what I told you in Nigeria. And so the suitcase is being used for walkie-talkies to allow the villagers to contact someone to get transportation when a woman needs to be transferred to a hospital. And in Burma, a doctor from Sacramento took the suitcases to the border of Thailand and Burma, where Burmese midwives took a suitcase we made for them that they stuck on their back and walked for days into the jungle to set up clinics so that women could have light during childbirth in Burma. And then last year when the earthquake hit, a number of people who knew about our project said, "Can't you help Haiti?" And at first I said, how can we do that? We're hardly even keeping up with Africa. But my husband, who has a heart that's the biggest in the world, of course said yes. And so soon we were trying to help out clinics that were in tent cities in Haiti. And here's, for example, a group that came from the States that went down, and they were using them to power a very high efficiency fan and lights for procedures. And then in some of the outskirts, it started being used by the midwives doing deliveries up in the mountainous areas where there was no electricity whatsoever. And there are other places I could show you as well. Well, what was also happening is that a number of people wanted to very much be involved in this project. And without going into it in much detail, I just want to tell you that there have been student groups in this state and in many states around the country who have wanted to learn how to make the suitcases. And because it's International Women's Group, I'm just going to feature one example, which is a girls group in Colorado. There's a group called Solar Energy International that does wonderful education programs around the world. Well, they were doing an education program with teenage mothers. These are not, engineering students. These are girls who are very, very young who have had their own babies. But they offered this class, and these girls got very excited about the idea of learning science and doing something that would help teenage mothers on the other side of the world, and they added their own flair. So where are we at right now? This little project just continues to grow and grow and grow. And next week, I'm actually headed with 2 of our team members to Liberia, because the World Health Organization contacted me several months ago and said, we've been really interested in the fact that energy seems to be very much related to healthcare, and not enough people are really looking at that relationship, and we're really interested in the work you're doing in maternal health. And we're going to propose a study that in Liberia, where 90% of the clinics do not have any power, that we bring in your solar suitcases and actually do a controlled study. We want to give half the clinics your suitcases, and then half we just want to leave them the way they are and actually document what kind of changes can happen by having some power. So I've been learning a lot more about Liberia, and one of the things that I have actually learned is that the maternal mortality rate is going up, not down. It's actually double what it was 7 years ago right now. So things are very critical, and I'm very honored to have an opportunity for us to try and go and make a difference. But I did make one deal with WHO. I said, I'm only going to do this study if we give those control groups light at the very end. And even though it's not in the budget, that's what we're doing now, is raising money to be able to give all the control groups light, because I feel like it's such an essential thing for doing adequate health care. One of the challenges we're going to face is that there's a huge rainy season in Liberia, and we're actually putting these things in next week, and the rainy season follows the next week. So we're putting larger solar panels to try and collect as much light as we can. And if you go to either Facebook or our internet site, you can keep posted on how that project unfolds over the next year. And here's a picture just to show you that this project only happens because of the dedication and love of a lot of people. My husband and I have been joined by wonderful engineers and scientists and technicians and inventory people and graphic artists, and so many people have just given of themselves freely to be part of this community. And so it's really only with that community that we could really pull this off. And we're now preparing 20 suitcases. In fact, someone in the audience wrote to me, why don't you raise your hand, Miriam? She just wrote to me a few weeks ago and said, I'm from Somaliland and I'm an engineer, I'd love to help. I said, come over next weekend, we're building suitcases. And so she's actually in this picture. So watch out. If you write to me, be careful. I may ask for help. And the other thing we're doing is a study in Nigeria where we're going to be studying in detail 12 clinics to try and see how do we make the suitcase as easy to use as possible for people. What are some of the factors that are going to make it work as well as possible? A lot of the conditions in which we place these suitcases have very terrible environmental conditions, either rain or terrible dust. And so we keep trying to improve the suitcase, and I brought this suitcase here to show you so anyone can see where it's at right now. It's already changed quite a bit just in preparation for this Liberia trip. So what does it mean to save the life of a mother? Why are we putting all this effort in? Well, in the communities in which I work, certainly just saving the mother is important in and of itself. She should live a very full and healthy life. But the meaning goes so far beyond that in these communities, because saving the life of the mother also means that her baby has a much higher chance of surviving infancy, that her children are less likely to be malnourished and more likely to go to school, and that her husband can use his time to be a productive member of society. So saving the life of a woman actually touches a whole village. It touches a community. And even though at this moment we've made about 50 solar suitcases, and we're probably making 50 more in the next couple of months, we realize that even if these clinics each see 100 or 200 people a year, that's touching 10,000 families a year. And now we're aiming to make 10,000 of these in the next 5 years, which actually is more likely to touch the lives of millions of families every single year. So sometimes it feels like the problems that I've described are just insurmountable. It feels like women are trapped, their situation is trapped, these problems feel almost hopeless. But one thing I tried to show you during this talk is that sometimes the solutions are not that far away, and maybe they're just around the corner and they can make a difference. And I don't want to leave you with the impression that light is the only answer. I really feel like it's a critical rate-limiting step in care, and one of the things that we want to do as an organization is actually also improve protocols and improve education. We have a lot of dreams for this organization, but I do think it is a critical piece of the puzzle. And I thank you all very, very much for your attention, and I'm here to answer any questions.